Good evening, everybody, and welcome to tonight's webinar on gestational diabetes, and thank you for taking the time to be here this evening. My name is Sandra Collins, and I'm part of the primary care support team at Sydney North Health Network. I would just like to acknowledge Australia's Aboriginal people as the custodians of this land and pay our respects and recognise their unique cultures and customs and honour their elders past, present and future. I'm sure those of you who've been doing Zoom meetings for the past 12 months are very familiar with this. You will be muted throughout this. If you want to submit questions to the speakers, please use the Q&A box, not the chat box. We'll try and answer all your questions after the sessions or at the end of the evening. And if we don't get round to them all, hopefully we can get them answered and send a follow-up email to you. We are recording this webinar and it will be available for viewing through the Sydney North Health Network website in a couple of weeks' time. And at the end of all this, you will be emailed an evaluation. Please take time to complete it and return to us because we do value the feedback, particularly with regard to what other topics you would like to have presented. Health pathways. Now, I hope that all of you are very familiar with health pathways, that you've been there and had a look. So I'm not going to labour the point, but I do have a short video that I'd just like you all to see.
Health Pathways is a platform that allows lots of different medical issues to be addressed. It's an educational tool for GPs. It's a referral tool for everybody who uses it. The ultimate goal is to improve the journey for the patient through the health system. We have basically mapped all the services related to a particular disease or cluster of illnesses. And having worked out what those services are, we can then share them with everybody so that the right patient goes to the right service.
To me, Health Pathways is almost like a roadmap to help GPs and healthcare workers to navigate the local healthcare resources. In my day-to-day practice, number one, it's a good resource for me to come across symptoms that maybe I don't come across all the time. So once I'm in, I either can search for the symptom or condition that I'm looking for, and there's usually a web page on that already. And then I scroll down, I can scroll through the red flag section, so I'm reminded as to what I need to look out for and not to miss. I scroll through the symptom checklists, practice points, relevant investigations, and also the management section. And of course, there's the patient resources and also referral pathways as well.
There's a lot of information coming into our inbox. And so sometimes you just kind of information overload. And when you want to look for something, you just have to say, okay, I read it somewhere, but where, I think the health pathway, that site, is work like a hub. So for us to just refer to, it's nice to know that, okay, I'll look for that in that place first. A lot of people put a lot of work into that pathway, so I would just trust them more than I just Google myself.
So there you have it. Here's the Health Pathways Gestational Diabetes is there, and the username, if you haven't been there, is Health Pathways, and the password is Gateway. And if you have any questions, please contact the Primary Health Network. We have a GP liaison, Helen Wainwright, who's more than happy to come to your practice and do a one-on-one and run through some Health Pathways information with you if you'd like that. So now moving on to our speakers this evening, we have two speakers, Associate Professor Sarah Glastras, who is a consultant endocrinologist at the Northern Sydney Endocrine Centre and a staff specialist at Royal North Shore Hospital. She is heavily involved in the management of diabetes in pregnancy at Royal North Shore and has a research program in type 1, type 2, gestational diabetes and maternal obesity. And then later on, we will have Dr. Emma Scott. She's also a clinical endocrinologist at the Northern Sydney Endocrine Centre and a staff specialist at Royal North Shore. She completed her PhD in glycemic variability in diabetes. And Emma's going to bring us up to date on SGLT2 inhibitor medications. So Sarah, welcome. Thank you for joining us, and I'll hand over to you to start your presentation.
Thanks very much, Sandra. Let me just share my screen with you. Okay, just to confirm everyone can see the slides. Sandra, can you just let me know that you can see them all right on the screen?
Yes.
Lovely. Okay, so thanks for your introduction, Sandra, and it's great to be with you this evening, everybody. I'm hoping this is a very practical and useful session for you all, and I'd be very happy to take any questions you might have about the management of gestational diabetes, because it's coming to you soon in hopefully a new form for many of you. So basically, my question to you is, how are you going to be equipped to manage women with gestational diabetes if and when you do antenatal shared care? So in order to help answer this question, we're going to go through some objectives of this evening's talk. The first is to understand and apply effective management strategies for gestational diabetes involving blood glucose monitoring, adopting healthy eating patterns relevant to the woman's cultural background, and then regular physical activity. To appreciate the importance, the implications for obstetric and neonatal outcomes in the context of gestational diabetes and what medications can be required. And then to gain knowledge really in terms of what the pathways are from GP shared care through to the hospital system and through to specialist obstetric and endocrine care when it's necessary. I'm going to show you this fairly complex flow chart here, and this will be available on the health pathways once we have that all approved through the necessary channels. But essentially, I just want to familiarize you first with this this flow chart so that you can see where we're heading with this discussion. So basically, I'm putting a ring around this section here, which means that if a woman between the gestational age of 24 to 28 weeks, if she gets gestational diabetes and she is having shared care with you, shared antenatal care with you as a GP, then rather than get flicked into the hospital system and then you never see her again, there is now going to be an option for you to continue to manage her with her pregnancy and the gestational diabetes in GP practice. And there are certain criteria that we'll talk about then transferring the woman to more specialist care if medications are required during the management of the gestational diabetes. So that's where we're heading. So what is gestational diabetes? So really it is diabetes that occurs in pregnancy, and really the matter of it is that it resolves at birth, at delivery of the baby. So sometimes you might see that diabetes might be first diagnosed in pregnancy, but actually we think it was pre-existing diabetes. So that's not what we're talking about here. We're talking about gestational diabetes where it's limited to the pregnancy and it's over once the baby's born. The mechanisms really are quite endocrine in nature, in that hormones are produced by the placenta, and this is important obviously because there's a nutritional role of the placenta for the growing baby, but as a result it really builds up insulin resistance in the mother. And when this occurs, the mother's pancreas needs to produce a whole lot of extra insulin by about 2 to 3-fold. And if this is not possible, if the pancreas does not step up to the job to produce enough insulin, well, then you get a blood glucose rise and eventually gestational diabetes develops. There's in fact an increasing incidence of gestational diabetes in Australia and in fact all over the world. 1 in 7 pregnant women in Australia are affected by gestational diabetes, and that data there is slightly old, 2016 to 2017. And you can see the graph on the right side of the slide there, really showing that really steep increase in incidence over the past decade. And that certainly has got to do with the diagnostic criteria that we use to diagnose gestational diabetes, and if you've been working for a while as a GP, you've noticed that yourself, that that some of the diagnostic criteria have indeed changed. But of course, alongside that, we've got increasing maternal age at the time of pregnancy, and we know that age is a factor in the development of gestational diabetes. There's an increased incidence of overweight and obesity. So in fact, in Australia, we've got 60% of women who are overweight or obese at the time of pregnancy, and 20% in fact in the obese range at the time that pregnancy is initiated. So all of those factors together really increase the likelihood of a diagnosis of gestational diabetes. And specific to our local health district, and the Northern Sydney local health district, that's currently 11%, which is slightly lower than the national average of 16%. So what if we don't diagnose and we don't recognise gestational diabetes? What are the consequences? And of course, women want to know this, because that's the reason why they're going to do the test and do the treatment and carry forward the plan. So, so the reasons is that if you let gestational diabetes go unchecked, then it can lead to fetal overgrowth. And what that means then is that the baby is getting excess nutrients from the mother, and as a consequence, large for gestational age babies can develop all macrosomia. And those two terms are really refer to a baby being big. The first one, LGA, is above the 90th centile for gestational age, and macrosomia is usually referred to as above 4 kilograms. The maternal complications of gestational diabetes are considerable. So gestational hypertension, preeclampsia, and then caesarean section are more likely. So both caesarean section when it's planned, but also emergency section when the baby isn't able to be birthed in the normal way, and hence emergency caesareans are increased in babies who are big and mothers with unrecognised gestational diabetes. And then the neonatal complications include birth trauma, again, really a consequence of being a big baby, and then neonatal hypoglycemia. And the mechanism there is really to do with the brand new pancreas in the baby being able to produce normal amounts of insulin in the setting of high sugar levels, and then being born and having that source taken away. And so hypoglycemia is certainly increased, particularly in that first 24 hours after birth to a mother with gestational diabetes. And hence special care nursery, the neonatal intensive care unit admissions is increased. And of course, we don't want that for the baby, we don't want that for mum, nor the healthcare system for that matter. So how do we diagnose? And I guess just to, not to labour the point on the last slide, but just to also inform you that we have very good data to suggest that if we then diagnose and treat gestational diabetes, that those complications for both mother and baby are certainly reduced significantly, and hence our treatment has efficacy in this area. So how do we diagnose gestational diabetes? So essentially we are screening women in early pregnancy for pre-existing diabetes separate to gestational diabetes. This has been around now since 2017, our LHD recommendation for diagnosis of diabetes in pregnancy. What we do is look for risk factors when a woman first presents with her pregnancy, and then if she has a risk factor, check an HbA1c. Why do we do this? We essentially want to establish whether it's likely that the woman may have had pre-existing diabetes coming into pregnancy, and we certainly want to know about that, because that is a high risk in terms of both obstetric and neonatal outcomes. So if an HbA1c is above or equal to 5.9%, it's really consistent with diabetes in pregnancy that is likely to have been pre-existing. And then the current pathway, which is no different from what it's always been, is to refer to the diabetes pregnancy service at the local hospital. And you can see the current risk factors for diabetes listed there. So I'll just run through them quickly. So a previous diagnosis of gestational diabetes, a previous elevated blood glucose level, maternal age above 40, various ethnic backgrounds, Asian, Indian, First Nations people, Middle Eastern, and then non-white Africans. So probably on par about 20–25% of most of our population. Family history of diabetes, so particularly a first-degree relative with diabetes, a mother, father, or sibling with diabetes or gestational diabetes. Pre-pregnancy BMI above 30, so hence we've already got 20% of our population there. Previous macrosomia, having a birth weight that would indicate a risk for having another large baby. Polycystic ovary syndrome, and then being on various medications, particularly steroids and antipsychotic medications. So really, that's actually quite a lot of risk factors. And if you apply that to our area of health, we've got about 30 to 35% of women who will actually have a risk factor for gestational diabetes, and all of them should have an early HbA1c measured. And I've just pulled this from the guideline, which is available again on the health pathways. And that is the flow diagram for what we do. Assess for risk factors. If there's risk factors, yes, and it's before 24 weeks of gestation, then perform an HbA1c, applying that diagnostic cutoff of 5.9%. And if it's above that, then referring to the local diabetes service. And otherwise, no risk factors, then standard course, which is to go through to 24 to 28 weeks and have the full one-step glucose tolerance test, which is the fasted 75-gram oral glucose tolerance test. And you can see there that those are the diagnostic criteria that we're using for the diagnosis of gestational diabetes: a fasting glucose of greater or equal to 5.1, a 1 hour value of or equal to 10, and then a 2 hour value equal to or greater than 8.5 millimoles per litre. And that is the WHO standard, and also supported by our Australian Diabetes in Pregnancy Society. So once we have a diagnosis of gestational diabetes, and this is becoming more relevant for GPs who are doing shared care, we will want you to continue to manage those women who are diet controlled with gestational diabetes going forward, if you are willing. So the principles of gestational diabetes are very straightforward, and they include healthy eating, physical activity of 30 minutes each day, blood glucose monitoring, and then medications if required. And the medications that we typically use in pregnancy include metformin and insulin. When it comes to insulin, our typical practice is to use detamir or levemir is its general name, or isophane or protophane, and then aspart or lispro, which go as Novorapid and Humalog. So those tend to be the insulins that we do use. When it comes to medications, we're not wanting or expecting GPs to initiate medications. If women with gestational diabetes need medications, then they should be referred to the hospital for specialist diabetes input. So registering with the National Diabetes Scheme is very important, because those little strips that you can see there that have their AccuCheck guide, which is the common meter that we do often recommend women to purchase, they are very expensive, those strips. And so so long as they have NDSS registration, then they will be able to get that subsidised by the NDSS scheme. And so women should have that NDSS form filled out and sent to the NDSS. At the moment, we will do that. So in terms of when you discover that a lady has gestational diabetes, she will come through to a group education session, and that will be part of what we do for that group education session. And much of what I'm going to tell you about lifestyle modification is in fact exactly what is spoken about in our group session that we run at Royal North Shore, and would be very similar to what is done at the other sites as well. So in terms of blood glucose monitoring, it is recommended that women do 4 blood glucose checks a day. So that includes a fasting glucose when they first wake up in the morning, not after they've walked for 30 minutes, but as soon as they wake up. And our intention is to aim for under 5 millimoles per litre. And then a 2 hour post-meal blood glucose reading, we want that to be under 6.7 millimoles per litre. And women often ask, is it from the beginning or the end of the meal? It is from the beginning of the meal. So 2 hours after starting their meal, they should check their blood sugar level and aim for it to be under 6.7. In some centres in Australia and even in Sydney, they apply a 1 hour glucose level, and that also is perfectly reasonable. And the number that you would apply in that context is 7.4 millimoles per litre. What we then want to do is monitor for patterns and hyperglycemia over a number of days to ascertain any problems with respect to what we're doing with lifestyle, and to ascertain whether we need to recommend a medication for the management of gestational diabetes. We like women to either write their blood glucose levels in a record book, or more recently, phone apps can be very helpful, and so that can be a more convenient way for women to keep their blood glucose records, and even can be virtually linked with a cloud system, either with the hospital or with yourselves if you're wanting to do that with your patients. So the dietary management of gestational diabetes, and I'll hasten to add that these are slides courtesy of our dietitian at Royal North Shore Hospital, Alexander, sorry. You can see there that all of these are pictorial, so we find that very helpful, that women really do like to see visually what is being recommended. So you can see a plate, and half of the plate should be vegetables, and then really aiming for a quarter of the plate being sort of a fist size of low GI carbohydrates in the form of pasta, sweet potato, rice, corn, bread, or legumes and lentils. And the legumes and lentils sometimes come as a surprise to women, that these can contain carbohydrates, so it's important, particularly for particular ethnic backgrounds, that they are aware of that. And then to ensure lean protein as well, because that's important both from the point of view of offsetting the carbohydrate loads, but also for adequate fetal growth during pregnancy. So ensuring that there is enough protein in the meal, and the recommendation is a quarter of a plate. And then we want to recommend to women that they stay away from the non-essential carbohydrate containing foods that you can see on the right side there, and really stick to much more whole grains when they're having carbohydrates. The aim of the game is not to avoid carbohydrates, so we want to make that message loud and clear, that it's very much about having the right kind of carbohydrates and spreading the carbohydrates out over the course of the day. And then in terms of what type of carbohydrates, again, whole grains are much better, and we want to be aiming for low glycemic index carbohydrates whenever possible. So you can see that there we've even got brands listed as to what patients might wish to choose. And so low GI rice, for example, is a good option, or brown rice if they can. Picking out multi-grain bread, and you can see a couple of different brands that we suggest there, and really being careful with cereals, and you can see some cereals there which are much better, so Guardian and All Bran, and then oats are very good. And then also thinking about the types of carbohydrates in the form of dairy. We don't want people to stop having dairy during pregnancy, but just picking the right types. And then we talk about exchanges, and so we do this because, again, we really want women to get the concept of spreading carbohydrates out over the day. So we don't want them to carbohydrate stack, for example, at the end of the day, and have this huge dinner meal and very little carbohydrates through the day. So the idea is to have 2 to 3 serves of carbohydrates at breakfast, lunch and dinner, and then to make sure that they have one carbohydrate exchange between each meal. And if they do that, then they'll get up to about 175 grams of carbohydrates a day, which is what the Institute of Medicine, which is US-based, recommend. So we can see there that a quarter of a cup of cooked rice, which is really not very much, as I think we'll all appreciate, is considered one carbohydrate exchange. So hence things like rice and pasta we need to be particularly careful with. And then in terms of the one carbohydrate exchange on the right side, these are good options for snacks essentially. So rather than leave a big pause between, say, breakfast and lunch being 4 or 5 hours, we don't want that when they come to do their glucose test at the 2-hour mark. That's a very good opportunity to have a snack at that time point. And that both helps ward off hunger, which of course leads to overeating if we get hungry, but also just spreading out that glucose feed to the mother and the fetus. And that's the purpose of doing that. So here's some examples of a meal plan that we might suggest to women. So you can see there oats for breakfast, a sandwich for lunch with some celery and carrot sticks and some chopped up fruit, and then dinner, a stir fry there. And then you can see snack options being fairly varied, but of course also being careful to ensure that there is enough dairy in the diet. We want to be pretty mindful about the fact that everyone doesn't eat like that last picture. And so here's an option for somebody of Nepalese background. And so you can see that we want to really individualize those meal plans. And that's why also we feel that having GPs who are seeing women perhaps from their own cultural background is actually very relevant and very helpful. Here's another option in terms of a Chinese daily meal plan. And you can see that is, again, being careful about those carbohydrates at each meal time. In terms of the likelihood that women will succeed with what I've just showed you, which is diet and really exercise as well, it's important to recognise that, you know, the data across Australia shows us that 50% of women will require a medication in pregnancy. So that means that 50% won't. So you'll be likely to keep 50% of the women in GP shared antenatal care. And just under a third of women in Australia are treated with insulin, and the other option being metformin. And then women who require medication are more likely to be older or born in the Middle East or Central Asia. And you can see that there is some difference in the graph there in terms of age and the likelihood that that medications will be required. So I think that's always helpful to have a bit of an idea of where a patient is likely to be heading. So what do GPs need to know? Well, the models of antenatal care are unchanged for women who are not going through GP shared antenatal care. So that's midwife-led antenatal clinics, either those at North Shore or satellites at Ryde or at Hornsby. The midwifery group practice, which runs very, very well, and women do like that model of care. And also in women who have other medical problems going on in pregnancy, there is, of course, the option to continue with an obstetric-led antenatal clinic. What is really important here is the model of care is changing for GP shared antenatal care, the option for women to continue to see their GP for their antenatal care if they are diet controlled. And that statement is really supported by our diabetes network as well as the maternal and neonatal network. So that's the bit, that's the slide I showed you right at the very beginning. So just again, reiterating that if an HbA1c is greater than or equal to 5.9% in early pregnancy, they can't go into shared care. They will go through the Clinic 1 and the SOC clinic at Royal North Shore Hospital for all of their antenatal and diabetes care, because we believe they have pre-existing diabetes. Those that have an HbA1c that is under 5.9 will go through to a normal glucose tolerance test at 24 to 28 weeks and apply those internationally recognised targets for diagnosis. And then if they have an abnormal glucose tolerance test, then they will get education, which is based on what I've informed you there. And then they'll come straight back to you. And if they continue with lifestyle modification alone, you continue the normal antenatal care pathway for shared care. However, if they do need medication, metformin or insulin, then they would go into the specialist obstetric clinic at the hospital. So important to note there that there is, of course, the regular visits to the hospital at 28 and 36 and 40 weeks of gestation, and then a fetal growth ultrasound in women with gestational diabetes is recommended at 34 weeks. So that will happen. And again, if there's some indication on that growth scan that there's something up with the baby either being too big or too small, then that would lead the woman down the path of needing to continue her management through the hospital system rather than shared care. And likewise, there's a very similar model at Hornsby, which is again essentially the same, except for the moment there is not the equivalence of a specialist obstetric clinic at Hornsby. At the moment, there's a hybrid between the obstetrician-led clinic at the hospital and the private endocrinologist who is linked in with that system. And that's very familiar to the antenatal team, the antenatal clinic at Hornsby. So they would direct your woman to where she needs to go if she in fact needs metformin or insulin. So the question is, I guess, how do you know whether she needs medications in pregnancy? And you will be reviewing her every week or two, depending on how she's going, and looking down her glucose levels. And essentially, if there's more than one glucose reading out of range at the particular time of the day, so that might be fasting, or it might be post-breakfast, post-lunch, or post-dinner. If her levels are above those targets and there's not a clear explanation, then we would like to see that woman for review in the diabetes clinic. So always ask the woman if she's eating enough, and sometimes women do, despite all of our recommendations, get the wrong message, and they think that they need to restrict what they're doing and they feel hungry. Well, if she's feeling hungry, then she's restricting. So that's a very helpful question. And ensure that she's doing adequate exercise. So not 3 hours a day, but not 5 minutes either. So half an hour a day is really the recommendation. If there's borderline results and it looks like she could get things under control with lifestyle, but perhaps is getting one reading above at various times of the day, then encourage gentle walks after meals, because that really does help. Encourage her to keep the meal size at the carbohydrate recommended intake, and spread the carbohydrates out during the day with snacks and meals. If there's 2 or more without a clear explanation, then we certainly do want to see her at the local hospital for a diabetes review, likely to start either metformin or insulin. So just to reiterate, the need to continue the antenatal care protocol, which is available on the health pathways as well, and that really has not changed. So nothing about that has changed. We'll continue to apply all of those things that are currently recommended if you do GP shared care. And then postnatal follow-up of gestational diabetes is really very important. It is important that we ensure that women have a oral glucose tolerance test 6 to 12 weeks after the baby is born, and we all recognise that that is inconvenient, and there's lots going on at that sort of timing after a woman's had a baby, so it's not the easiest thing to attain, but it is important to make sure that the gestational diabetes truly was gestational diabetes and that it has gone away. Because sometimes you can get diabetes in disguise, for example, type 1 diabetes or MODY, for example, and we just want to make sure we're getting an opportunity to pick that up. And of course, it's a good time to ensure that they haven't continued to have some form of pre-diabetes or type 2 diabetes, and the glucose tolerance test certainly remains the gold standard. Up to 50% of women will get gestational diabetes within 20 years, and 5% will develop within 6 months. And that's Australian data. Up to 70% of women with gestational diabetes will get it in a subsequent pregnancy. So I want to encourage ongoing lifestyle modification and weight management postpartum, not to the extent that we do in gestational diabetes, but certainly making sure that those take-home messages are there to ensure that the weight, pre-pregnancy weight is achieved, for example. Educate regarding the need for screening every 2 years, which is the current recommendation, and provide pre-pregnancy planning support and diabetes screening for a subsequent pregnancy. So that's all very important, because certainly don't want to have a woman go into pregnancy with unrecognised pre-existing diabetes after a GDM experience, because that certainly has very big risks for the baby. So I hope that's been clear. I know that's a fair amount of information, rather simple, but nonetheless a fair amount of information to take in. So I'd like to open it up to you all now to ask me any questions about the management of gestational diabetes, and particularly about the shared care for GDM.
If you've got any questions, please put them in the questions and answer box. And I'm just wondering, I can't actually put any questions in there. If it's not working, can you let us know through the chat box, please? Thank you.
I do have a feeling that our Q&A box mightn't be working.
So I've just asked Judy if we can unmute any of the participants. So while we're trying to work on that one, perhaps we'll hold on to your questions and we'll move on to Dr. Emma Scott.
Oh, we do have one question.
Oh, we've got one.
That's good. Thank you very much for your question. So we have a question here that is metformin the only oral medication for a pregnant patient? And the answer to that is yes. So we don't use sulfonylureas in pregnancy. We don't use SGLT2 inhibitors. We use metformin and we use insulin, and that's about it. So those really are the treatments for the management of gestational diabetes.
Liz, I see you're online, Dr. Liz Miles, who is a general practitioner at the Hornsby GP unit. Do you have anything you want to add to the comments?
Emma, did you have anything to add? Because Dr. Emma Scott, who's going next, she certainly does a lot of gestational diabetes management, as I do. I don't know if you had anything you wanted to add, Emma.
No, I think that was really nicely covered. Oh, here we go. We've got another question. Anonymous attenders working in a busy medical centre still can be one example of exercise. I think it is challenging, particularly for women who are working up until the end of pregnancy, and if they're, in desk jobs, it can be quite challenging for them to achieve that exercise after meals. And often they'll say they don't have time, or, but I think it's just encouragement, that were the messages we've gone across, that small changes in terms of exercise and dietary change can mean they have a completely healthy, normal pregnancy.
Yeah, I have to be a bubble burster to the person who asked the question. No, it doesn't count. So just walking around our workplace isn't really enough in terms of actual exercise and what that does in terms of like you moving insulin and glucose from the bloodstream and actually into muscles where you want it. So despite being really busy, it's not enough in my experience anyway. Best to put on your jogging shoes and go for a walk for 20 minutes, half an hour when you can, or break it up into 10-minute sessions if it's really not possible to do half an hour altogether. What's the best recommendations for a patient that has horrible nausea? Yeah, that's a really good question. That's very difficult. That it's obviously futile to ask women who have terrible nausea in pregnancy to move to carbs in that sort of structured way that that I set out, if in fact they can't do that and they keep vomiting. So of course in that context we just have to make sure that she's not having big pauses during the day without any carbohydrates, and sometimes the only carbohydrates that she will tolerate are more higher GI ones. And then we just have to, I think, work around that and make sure she is actually achieving the glycemic targets that we set up, because we still don't want to miss her in terms of giving her medications if that's what is required. And just keeping an eye on gestational weight gain as well, and making sure she's not sort of losing weight in pregnancy. So anyway, I hope that was useful, and that it will help help you all keep your patients in GP shared care, because I think from the patient journey point of view, this is really welcome for women. They do not want to have to go from being in their lovely GP shared care model to having to wait for a few hours and park in a car park as well at the hospital. It seems like a real rip-off when that happens. So yeah, I think this will be a nice welcome change for many women. There's another question here, which is, if a woman is on metformin for ovulation induction for PCOS, would you stop it once she conceives? And yes, the answer is I would. I think that there's enough evidence now to show us that we don't really need to continue metformin throughout the first trimester of pregnancy. It doesn't achieve or offer anything more. And of course, it's hard then, it blurs the criteria for the management of diabetes if someone's still on metformin. So if she gets diabetes in pregnancy or gestational diabetes later on, then that's fine. It might be an option that we reconsider at that point, but I wouldn't keep her on metformin just because she needed it to get pregnant. Would you agree there, Emma?
Yeah, absolutely. And obviously you're going to be doing screening anyway for someone with PCOS for early diabetes in pregnancy.
Okay, well, I'll call it a wrap up on the GDM GP shared care model.
Thanks, Sarah. If you want to stop sharing, and Emma, over to you. Thank you very much.
No problem. Okay. So I just wanted to do a bit of an overview on SGLT2s, and with particularly a practical focus on ketosis associated with SGLT2s, because that's something I think we need to be really aware of. So a bit of a background refresher on mechanism of the SGLT2s. So as you know, glucose is filtered by the kidney, and predominantly around 90% of glucose is reabsorbed in the proximal tubule by the sodium glucose coupled transporter SGLT2 in the proximal renal tubule. And there's a little less reabsorbed by SGLT1, around 10% of filtered glucose. And clearly when someone is hyperglycemic and there's more glucose being filtered into the kidney, we don't really want to be reabsorbing that. That's detrimental for glucose control. So blocking this SGLT2 transporter with an SGLT2 inhibitor means that less glucose is reabsorbed, resulting in glucosuria and a lowering of blood glucose. The amount of urinary glucose that is increased with an SGLT2 inhibitor is around 80 to 100 grams per day. And it's really important to note that this is completely independent of the action of insulin. And this is shown again in this diagram. So we have the SGLT2 and SGLT1 receptors in the proximal tubule of the kidney. The SGLT2 transporter here is reabsorbing 90% of glucose, and it's important to note that it's reabsorbing both glucose and sodium, which is important when we talk about later on some of the cardiovascular benefits of an SGLT2 inhibitor. SGLT1 down below is only reabsorbing around 10% of the filtered glucose. SGLT1 is in the renal tubule, but it's also located in the intestine. The SGLT2 is a really high capacity transporter, and it's insulin dependent. They both are. And here's that this is demonstrated again in an individual with hyperglycemia. Increased plasma glucose means more glucose filtered at the kidney, and majority of this is reabsorbed early on by the SGLT2 in the proximal tubule, and a smaller amount by SGLT1 later. If we block this with an SGLT2 inhibitor, there's reduced glucose reabsorption, glycosuria, and a lowering of plasma glucose. And the beauty of these drugs is that as plasma glucose falls, there's less glucose filtered to the kidney, and therefore there's less reabsorption in the proximal tubule. So generally these agents are not associated with hypoglycemia unless they're used with an agent that would otherwise cause hypos, like insulin or a sulfonylurea. What's the impact of these drugs on HbA1c? And this is a summary slide on the use of canagliflozin using two strengths in the orange and the grey. And generally these are 26-week studies. So looking at the use of SGLT2 with monotherapy, it lowers the HbA1c from baseline by about 1%, and with dual therapy between sort of 0.6 and 0.8%. And when we're looking at SGLT2 inhibitors as a class, they will generally lower the HbA1c by about 0.4 to 1.1%. But obviously that will differ depending on what the starting HbA1c is. So if someone's starting with poorer glycemic control or higher HbA1c, they may have a greater lowering effect. And I've summarized this here as well. So we've got the canagliflozin, dapagliflozin, empagliflozin, and ertagliflozin. So DAPA and empagliflozin is what we would be used to in Australia. So we can see the mean HbA1c lowering of these drugs is around 0.7%, lowering blood glucose by around 3%, 3 millimeters of mercury rather, and around a 2 kilogram weight loss. But we know it's not sufficient for an agent just to lower blood glucose to be approved. We also need to show now that there is not a detrimental effect on cardiovascular outcomes, and that's recommendations from EMA and FDA prior to drug approval. And that led to the publication of studies which we're very familiar with now. So the EMPIREG study, which came out in 2015. And this was a study of around 7,000 individuals with type 2 diabetes who are randomized to empagliflozin or placebo and was studied for around 3 years. And just to show that the outcomes, so the empagliflozin in the red significantly reduced the risk of the primary outcome and significantly reduced, and this was a composite of death from cardiovascular causes, non-fatal MI or fatal stroke. There was also a significant reduction in hospitalization for heart failure and death from cardiovascular causes. So quite a significant study, and you can see that the curves deviated really early. So we were seeing this effect of the SGLT inhibitors really early. And this study led to further studies on SGLT2 inhibitors, the canagliflozin study, the CANVAS program, very similar, looking at individuals with type 2 diabetes who had pre-existing cardiovascular disease, randomized to 2 strengths of canagliflozin and then studied for the occurrence of cardiovascular events and other events. The canagliflozin in the darker grey significantly reduced the risk of cardiovascular death or hospitalization for heart failure, fatal or hospitalization for heart failure, again in the dark line, a lower risk, and a significant reduction in hospitalization for heart failure. And I've summarized the trials as we know it here. So only the canagliflozin and the empagliflozin studies had a significant reduction in the major adverse cardiac event. Dapagliflozin didn't have a significant reduction in the MACE criteria, but it's important to think about the fact that the study populations were very different in these drugs. So the dapagliflozin group probably had people with less pre-existing heart disease, cardiovascular disease, and there were also differences in the gender across these studies. So probably not similar populations. However, all of the drugs significantly reduced the risk of heart failure or hospitalization for heart failure, with hazard ratios around 0.6 to 0.7, and all significantly reduced the incidence of the combined renal endpoint. And that was different by trial, but generally the SGLT2 inhibitors slowed the decline in EGFR, slowed the rise in creatinine, slowed the need for dialysis or renal death from a renal disease. But we know that these drugs have a renal-based mechanism, and so when EGFR declines, we're no longer able to use these agents. And in Australia, with the empagliflozin, we're not able to use these drugs with an EGFR below 45, and with dapagliflozin, we're not able to use them with an EGFR below 60. But it's important to note that glucose lowering effects might decline as EGFR drops, but the other benefits of these drugs may persist, in particular some of the cardiovascular benefits, which are of particular interest. So this systematic review and meta-analysis was looking to see, do we see those benefits in terms of reduction of cardiovascular disease and heart failure when the EGFR is not optimal? So this was a study of people with an EGFR below 60 mils per minute, and the mean EGFR ranged from about 38 mils per minute to 53 mils per minute. And you can see here with the boxes on the left-hand side, this will favor the SGLT2 inhibitors. On the right-hand side, this will favor placebo. But you can see in individuals with an EGFR below 60, looking at canagliflozin, dapagliflozin, and empagliflozin, there was still a significant reduction in the major adverse cardiac events with a hazard ratio of 0.81. There was also a reduction in myocardial infarction. There was not a similar effect seen in the risk of stroke. There was also, perhaps not surprisingly, a really significant reduction in the risk of heart failure with a hazard ratio of 0.61. What I think is interesting is in this population who already had a low eGFR, these agents seem to have a renoprotective effect. So the SGLT2 inhibitors slowed the rate of eGFR decline by about 1.35 mils per minute per year, and also had a significant reduction in the renal composite outcome, which was doubling of serum creatinine, end-stage kidney disease, or renal death, which you can see here on the left. So increasingly, there's now an interest in the role of SGLT2 inhibitors outside the realm of diabetes. So looking at these drugs as a cardiovascular tool, because there's such a strong impact on reduction in hospitalization for heart failure. So I'm just going to touch on a few slides relating to the benefits in SGLT2s in heart failure. So the first from NEDGEM in 2019, looking at dapagliflozin in patients with heart failure and reduced ejection fraction. So this study was a phase 3 placebo-controlled trial. It had nearly 5,000 patients with heart failure, New York Heart Association class 2, 3 or 4 with an ejection fraction of 40% or less, and sort of roughly 50-50 they had diabetes or they were normoglycemic. They were randomized to dapagliflozin or placebo and other recommended therapies, and they wanted to see, was there a difference in the composite outcome of hospitalization or hospital treatment for heart failure or cardiovascular death. And spoiler alert, the dapagliflozin did reduce that composite outcome. So it did reduce the risk of worsening heart failure or death from cardiovascular disease in those patients with diabetes and those who did not have diabetes. And I'm going to show some slides on that in a moment. This was followed up by the empagliflozin study from 2020, a very similar study, looking at patients with heart failure. And this was a smaller study, around 4,000 patients, again with class 2, 3 or 4 heart failure with an ejection fraction of 40% or less. In this circumstance, they were randomized to empagliflozin or placebo in addition to standard care. And the outcome was the same, that composite of cardiovascular death or hospitalization for worsening heart failure. And again, the empagliflozin reduced that composite risk in those people with and without diabetes. So I just want to touch a little bit on this meta-analysis, which combined the results from the empagliflozin and dapagliflozin heart failure trials. So here we've got, there was a significant reduction in the risk of all-cause mortality with a hazard ratio of 0.87, and there was a reduction in cardiovascular death as well. There was also a really significant reduction in that primary outcome, as I mentioned, for hospitalization for heart failure or cardiovascular death, where you can see a hazard ratio of 0.74. And that was really strongly driven by hospitalization for heart failure, where you can see a hazard ratio of 0.69. They then stratified these results by patients with or without diabetes. So on the top, it was individuals with diabetes. You can see a hazard ratio for that primary outcome of 0.74. And those without diabetes, a hazard ratio of 0.75. So nearly identical. This really isn't being driven by that glucose lowering effect of these drugs. It's clearly a mechanism separate to that. They then stratified the results based on eGFR below 60 or above or greater than 60. And again, both groups had similar reductions in the overall primary outcome with hazard ratios of 0.77, where the eGFR is reduced, and hazard ratios of 0.72, where the eGFR is greater than 60. So in summary, what we know is that the baseline and change in HbA1c or blood pressure or cholesterol doesn't seem to be linked, doesn't relate to the cardiovascular benefits that we're seeing in these drugs. And what I've tried to show you in a little snapshot of the data is that the benefits on hospitalization for heart failure or cardiovascular death has been shown across a wide variety of renal disease. So those benefits have been seen in people with an EGFR greater than 90, but also EGFRs between 30 and 60 mils per minute. We know that the glucose lowering benefit of these SGLT2 inhibitors drops as EGFR drops, but clearly those cardiovascular benefits are preserved. And the benefits of these agents are consistent in those people with or without diabetes. So really interesting. So what's a possible mechanism that might be explaining what we're seeing in the trials over the last couple of years? Well, on the left-hand side, we have an example of the kidney, for example, diabetic nephropathy, a proteinuric kidney. So you can see the afferent arterioles leading into the glomerulus are quite dilated. Within the glomeruli itself, it's dilated with fibrotic loops, and this was resulting in proteinuria, which you know is the hallmark of diabetic nephropathy. If we look at a kidney on the right, which is treated by SGLT2 inhibitors, this has a natriuresis osmotic effect, and through juxtaglomerular feedback, that results in afferent arterial constriction, which reduces the intraglomerular pressure, and this results in a reduction in proteinuria. So that's proposed really how the renal protective mechanism may be at play. Other mechanisms are really still under investigation. If we look at the heart on the left, this is an example of a heart with diabetes associated sort of heart failure. So you can see the thickening of the ventricle with ventricular hypertrophy. There are increased cytokines, inflammatory cytokines, extracellular matrix remodeling. There's an impaired cardiac metabolism where the heart is relying on non-esterified fatty acids as a fuel. And there's also apoptosis of the cardiac myocytes. So how might the SGLT2 inhibitors help to sort of modify this process? And I should add that sort of diabetic heart failure has been an entity which has been very, very challenging. There's no sort of direct treatment for this. To date, it's very challenging to treat. So how might these SGLT2 inhibitors have a role? So number one, it's felt that it's through that improvement in ventricular loading, through a reduction in preloading, through that natriuresis and osmotic diuresis, which I've talked about as the main mechanism of the SGLT2 inhibitors. It's thought that there may also be an improvement in cardiac metabolism. So these drugs are associated with an increased reabsorption of ketone bodies, and ketone bodies are thought to be a better fuel, a better energy source for the heart than those non-esterified fatty acids. So that may have a role in why this has a benefit. The SGLT2 inhibitors might have a direct impact on the myocardial sodium hydrogen transporters, and I will show that in the following slide. In basic science model, these agents have been shown to have an inhibition on collagen synthesis, reducing the fibrosis within the heart, and may also have an anti-inflammatory effect. So here, this is the sodium hydrogen exchange. So this is in the exchanger in the red, which is shown on A and B. And normally this exchanger results in increased cytosolic sodium and calcium. And this increased sodium and calcium is detrimental. It's involved in the pathology of heart failure. And we know, interestingly, that in a diabetic heart with heart failure, these sodium, hydrogen, ion transporters are upregulated on the surface of the heart. So the SGLT2 inhibitors will directly inhibit these transporters, which results in a reduction in cytosolic sodium and calcium. And this supposedly will have a benefit in the reduction of the pathology leading to heart failure. So what are some of the adverse effects of the sodium glucose SGLT2 inhibitors? We know about these from clinical practice, but also the clinical trials. We know that polyuria and dehydration is really common, and that is certainly much more common if you're starting this agent on someone who's got really poor glycemic control. Then you might expect that they're likely to have more of these side effects, and it's certainly something you should warn the individual about. We worry about genital and urinary tract infection, and there's been reports in clinical trials of up to 11% increased rate of mycotic infections and rare conditions like the Fournier's gangrene. So it's something that I always tell my patients about. just cautioning about the risk of genitourinary infections. I generally advocate, and the trials would advocate, that if you have an individual who has one urinary tract infection or genital infection, then you should treat as per standard. But if someone is having recurrent infections, then you may wish to consider changing the agent, or you might not consider treating this individual with an SGLT2 inhibitor because potentially they're at an increased risk. Peripheral amputation. So the jury's a little bit out on this. So from the Canvas study, the original Cannifer-Gozan study, there was an increased risk of peripheral amputations, but this wasn't seen in the Credence study, which was another canagliflozin study looking at in renal impairment. So it's really unclear, as is this potential increased risk of fracture. But what seems to be pretty consistent across the SGLT2 inhibitors is the risk of euglycemic ketoacidosis, which is what I want to focus on in the last couple of slides. So this is a meta-analysis, I think, from 2019, maybe looking at the incidence of diabetic ketoacidosis. So there were 72 trials, and of those 9 reported at least one episode of ketoacidosis. And they looked and thought, overall, the risk is pretty low. There didn't seem to be an increased signal for the risk of ketoacidosis when the drug was properly prescribed. But what I would say is this is a meta-analysis from randomized controlled trials. So we know this is a completely different setting to real-world practice, where we don't have the strict protocols in place and they're a different patient population. So I think it is an important thing that we need to be aware of and educate our patients about. So this is from an Adelaide Australian group, and it was a systematic review of diabetic ketoacidosis with SGLT2 inhibitors in the perioperative setting. So they looked at 33 publications and they identified 42 cases of euglycemic diabetic ketoacidosis and 5 cases of hyperglycemic diabetic ketoacidosis. And there was a really varying time of onset. So the onset of diabetic ketoacidosis occurred within a few hours of surgery, but could happen for up to 6 weeks after surgery. And interestingly, quite a large proportion of the cases, so 13 cases, 12 with euglycemic diabetic ketoacidosis and 1 with hyperglycemic diabetic ketoacidosis, occurred in the context of bariatric surgery. And 10 of these noted that there'd been a reduction in caloric intake, sort of this contribution of starvation, which had precipitated the ketosis and ketoacidosis. So that table up above is just looking at what other risk factors were there apart from being on an SGLT2 inhibitor and having surgery. What were the other precipitants? So intercurrent illness was very common. Dietary modifications, as I've mentioned, also precipitated diabetic ketoacidosis, and that might be preoperative, very low-calorie diets, post-operative, low-calorie diets, or just a reduced oral intake post-op. Medication changes were extremely common, and particularly continuing perioperative use of the SGLT2 inhibitors, or even continuing the SGLT2 inhibitor after surgery, which occurred in 17 of the cases. And also really important to note that in 6 of the cases, insulin had been stopped, or there'd been a significant reduction in the dose. And the other thing to be aware of is that some of these cases were perhaps because the drug was prescribed in not the right patient. So they might have had thought to be type 2, but in fact had type 1 diabetes or had latent autoimmune diabetes. So really wasn't appropriate that they were on an SGLT2 inhibitor in the first place. This is a study from Singapore, again, looking at what precipitants are there for SGLT2 ketoacidosis. So in the majority of cases from this study, the ketoacidosis occurred within 6 months of starting the drug, and it was more common in women. But other precipitants were reduced intake, so Ramadan fasting, low carbohydrate diet, alcoholism, low medication adherence, insulin dose reduction cessation, similarly to the Adelaide group, and acute illness, which occurred in 70% of the cases. Skip over this, but just briefly, why does it form? Why do the SGLT2 inhibitors, how does it result in ketoacidosis? So the SGLT2 inhibitors, by the mechanism I mentioned earlier, result in glucosuria, which reduces blood glucose, which then acts on the pancreas beta cells to reduce insulin secretion. So that reduction in insulin secretion, as well as a direct effect from the SGLT2 inhibitors on alpha cells, results in increased glucagon. This combined with stress, whether it's acute infection, whether it is surgery, increases counter-regulatory hormones like cortisol and adrenaline. And this results in proteolysis and lipolysis, increased free fatty acids, and gluconeogenesis and ketogenesis. And if you look on the other side here, the same as the ketones are being formed, the SGLT2 inhibitors are reabsorbing ketone bodies. And that's a really important thing to note, because if you're assessing a patient thinking, do they have SGLT2 inhibitor ketosis or ketoacidosis? If you're just looking for ketone bodies in the urine, they might not be there, because the SGLT2 inhibitor is reabsorbing the ketone bodies. And really where you need to be measuring for ketones is on a finger prick. So the ketosis with gluconeogenesis will result in either euglycemic diabetic ketoacidosis or hyperglycemic DKA. It's important to remember that if you're seeing a patient who's got ketones but has a normal blood glucose, that it might not be SGLT2 inhibitor diabetic ketoacidosis. It could be starvation ketosis. It's very topical. We've just heard about diabetes and pregnancy. It could be pregnancy, which we know is a very ketosis-prone state, and could be rarer causes like pancreatitis or drug toxicity and other things. If we want to think about what can we do to minimize the risk of this occurring, then a lot of it comes down to appropriate patient selection for these agents. So I would generally say someone with type 1 diabetes, they're at a higher risk of DKA. I would not be using these agents outside of a clinical trial setting. If you have someone in front of you who's been labeled as type 2, it's important just to think, are they truly type 2? If they have features that maybe would be suggestive of latent autoimmune diabetes, like younger age, they're not phenotypically looking like a type 2, rapidly deteriorating HbA1c, then perhaps reinvestigate to confirm the diagnosis before you start down the SGLT2 pathway. If there's someone with type 2 diabetes, then we need to think about, are they on insulin or not? If they're on insulin, then theoretically, they may have insulin deficiency, and therefore they're at a higher risk of DKA. And so you might want to think about stabilizing the insulin dose before you start these drugs, making sure they're compliant. And also it's really important to talk about sick day management. So making sure that when they're unwell, they don't stop the insulin, they don't inappropriately reduce the insulin, they stop the SGLT2 inhibitors, and they test for blood ketones. I know in my experience, this doesn't happen very often, but it is really important to stress. If someone is not on insulin, then you need to ask yourself, well, is it suspected that they have insulin deficiency? Are they someone who does prolonged fasting or has a ketotic diet? Are they someone who has an alcohol dependency or poor medication adherence? And if the answer is yes, then again, they might be at a higher risk of diabetic ketoacidosis. So again, if you think they're insulin deficient, then you might want to start or stabilize insulin before you add in the SGLT2. Really important to talk about the sick day protocol. So again, stopping these agents when people are unwell, testing for ketones, making sure they're not on a ketotic diet, and monitoring the adherence of these drugs. So I just want to briefly touch on the ADS guidelines for peri-procedural management of these agents. So really important when you're prescribing these drugs that you provide written and verbal advice about the risks of diabetic ketoacidosis. And I'll show an example of a management plan on the last slide. For surgery and procedures that require at least 1 or more days in hospital, including colonoscopy or bowel prep, the SGLT2 inhibitors need to be stopped 3 days prior to procedure, where the 3rd day is the day of the surgery. For procedures that might just be day, the SGLT2 inhibitor can be stopped for the day of the procedure, but I think there's still risk, particularly if the patient is fasting. So to minimize confusion for my patients, I generally just say the 3-day prior to procedure rule. On the day of admission for the procedure, it's important that the team measures blood glucose and ketone levels. And if the patient is well and they're not ketotic, then the procedure can occur. But we might consider still testing for blood glucose and blood ketones during the procedure and after the procedure to minimize the risk of that missing diabetic ketoacidosis. And if the SGLT2 inhibitor hasn't been stopped, then we need to think about, well, should this procedure occur? So in someone who hasn't stopped the SGLT2 inhibitor prior to the procedure, we'd measure the ketones and do a base excess. So if ketones are less than 1 and base excess is more than -5, then they're not ketotic, they don't have acidosis, so the surgery can occur, but again, we need to be monitoring for glucose and ketones both during the procedure and after the procedure. If ketones are more than 1 and base excess is more than -5, then they're ketotic but not acidotic. And generally, you need to consult with the endocrinology team as to whether that procedure should actually occur. If they're acidotic, then really, unless it's critical, the surgery shouldn't happen, and we need to be stabilizing this patient on insulin and dextrose. If at any point in someone who's been on SGLT2 inhibitor, the ketone is above 1, then we need to think of this as like a type 1, a DKA. We need to be assessing for acid base, consulting critical care teams, consulting endocrinology, and then we'd likely put them on some dextrose or insulin to lower those ketones. I think the really important part of this guideline is also thinking about when do we restart these agents? And I think that's really when we rely on you all, on our GP colleagues, because often if someone is unwell in hospital, I stop the agent straight away, irrespective of whether they're coming in for surgery or not. I'd stop in hospital, and I would really only restart that agent when I'm 100% confident they're well. And that's likely to be when they come to see you for follow-up after discharge. So it's really important that that message is got across to the patient. So this is just a quick example from the RACGP guidelines of a sick day plan for someone with type 2 diabetes. And it does mention the importance of ketone monitoring if you are taking an SGLT2 inhibitor, and when to notify your doctor. And it sort of says that if you're unwell, then you should stop taking, insert here, your SGLT2 inhibitor. So I think it's just a guide for something you might use when educating patients when starting the SGLT2. I'd like to acknowledge Professor Greg Fulcher, who provided some of these slides, and I'm happy to take any questions.
Emma, Sandra here. There's one question on the chat box which says, how do you check ketones on a finger prick sample? I thought our machines only report BSL.
So it depends on the glucometer that you have. So some of the Optium meters, they need to actually purchase the patient would need to purchase a ketone strip, and often that's quite expensive. But some of the glucometers will measure both blood glucose and blood ketones. Generally, the blood glucose strips are blue and the ketone strips are purple in color. So it is a different strip that needs to be used.
Emma, can I ask you a question? I'll just get my video up. So you mentioned, or you went through the evidence around the benefits of the SGLT2, even where the eGFR is less than 60. So I'm just wondering, how hard is that limit in terms of our prescribing?
Look, and certainly if you look at MIMS, if you look at the drug guidelines, it's quite clear that we shouldn't be using these with an eGFR cutoff. So the lowest would be 45 with Jardiance. In clinical practice, sometimes if I'm working with a nephrologist, if someone has proteinuria kidney disease, particularly if they're already on an SGLT2 inhibitor and I see there's a bit of decline, I'm generally happy to be a little bit more flexible. But I would probably say as a general rule to stick by the prescribing guidelines, and then if in doubt, consult one of us, like Sarah or myself, or the nephrology team, because I think that may slide a little bit. I think we may just change the way we look at these drugs. We might stop thinking about them as just glucose lowering drugs. We might start thinking of them about renoprotective drugs or cardioprotective drugs. So I think dial a friend. Sometimes the lines can be a little blurred.
Thanks.
So that's the end of the working groups, and if there are any working groups that you...
Sorry, I can't quite hear the question.
No, I'm not sure who was speaking there. If you have a question, please put it into the Q&A box. I think that would be the easiest. Thank you. Emma and Sarah, you've obviously answered everybody's questions perfectly. I'll just give them a few more moments to think about that. And I have just been rummaging around in health pathways, so information on the SGLT2 inhibitors is in there with regard to the number of days to withhold before surgery. So please do go there and have a look.